the topic of discussion that we are going to have right now is minimal change disease. Now this okay, and the series that will follow is we will just go through we'll go through the content of the notes, and we'll just look toward the diagrams, right? And we'll have a quite a recap through another note, and at last what we'll do is we'll go through the content of first aid. So without delay, I would like to take you toward the discussion. So minimal change disease. Now what is this minimal change disease? This minimal change disease, it is a example of what? Nephrotic syndrome, right? Nephrotic syndrome. Okay, if you have one watched nephrotic lecture on nephrotic syndrome, then we have discussed in detail, right? Okay, what is this minimal change disease, right? From the name it is clear that there will be what? There will be minimal change in what? Level of glomeruli. There will be minimum change in level of glomeruli. Okay, and another thing that we need to know here is it is what? It is immune dysfunction. What is this? This is our immune dysfunction. Immune dysfunction, right? And because of immune dysfunction, okay, it is immune dysfunction causing what? T cell mediated release of cytokinin, right? T cell mediated, right, release of cytokinin. Now here, right, there will be what? There will be release of what? Release of what? There will be release of proteases and oxidant. And as there will be release of proteases and oxidant, what will happen is that, right, and as there will be release of protease and oxidant, these will go in the area podocyte and they will cause podocyte damage, right? And podocyte damage is what we call what we call podocyte damage. We call it as podocytopathy, right? And as podocytopathy or podocyte damage will happen, what will happen is that there will be increase in excretion of protein, that we call proteinuria, right? Increase in excretion of what? Protein, that is what? Proteinuria. But here in minimum change disease, what is going on is that there is minimum damage to podocyte, not excessive. So here the proteinuria is what? It is selective proteinuria. That means only albumin like substance with low molecular weight, or albumin like protein with low molecular weight will be excreted, right? They will be excreted out. So what? And this is how this minimum change disease, and this is what? This is selective proteinuria having what? Nephrotic syndrome. Now here the thing that I would like to take you toward is, right, now another thing is that, right, one important fact about is that it is the most common cause of what? Nephrotic syndrome in the case of children. And this is the important point, right? What? Most common cause of nephrotic syndrome in children. So you can highlight change and our C, right? Children's C. So okay, now talking about its etiology, right? Mainly it is idiopathic, right? But it is found in the patients who are intaking what? NSAIDs like drugs. It is also found in the persons having Hodgkin's lymphoma, respiratory infections, right, and atopy. So as we have already said that podocyte damage will be taking place, right? And what? In child, right? In child, and excessive proteinuria will occur. And excessive proteinuria, what is how it is presented? It is presented as frothiness in urine, right? Frothiness in urine. And because of excessive loss of protein, albumin, there will be what? There will be swelling, edema also. So frothiness, as you can see, what is this? This is our frothiness, right? And this is our what? This is our what? Swelling or edema, right? In mainly in periorbital region. So okay, now how we are going to diagnose it, right? Now to diagnose it, what we'll do is that we'll have what? We'll have blood examination, urine examination, and renal biopsy. And out of these three, the renal biopsy is the best procedure, and renal biopsy in which there is what? There is electron microscopic study. So in blood, what we'll see the decrease in level of albumin, right? Increase in lipid level, yes, that's true. And in urine, what we'll see is we'll have what? We'll just have the sample, 24-hour sample of urine, right? And this 24-hour sample of urine, it should be what? It should be kept so appropriately, right? By maintaining temperature, so that because of what? Because of evaporation, the level of urine should not be lost. So nowadays there is a special technique of doing this thing. That means we don't need to wait for 24 hours, because nowadays we calculate what? UPCR. Now what is this UPCR? It is what? Urine protein, right? And our urine creatinine ratio, right? UPCR. Okay, this is the ratio of urine protein and urine creatinine. And it also shows the what? It also gives the values that are equivalent to our what? the reading that is done in 24 hours. Okay, so this is one important process that is practiced nowadays. And talking about electron, okay, now talking about what renal biopsy, it is the most efficient way, and here we can do three things. One is light microscope, electron microscope, and immunofluorescence. And talking about light microscope, what we'll see is we'll see normal minimal change, right? Minimal change, the word here in light microscope we don't find anything at all, right? It is normal. But in the case of electron microscope, what we'll see is we'll find effacement of porocyte, right? And it is confirmatory diagnosis. Now what is this effacement of porocytes? Effacement means what? Okay, yes, we have discussed this in our nephrotic syndrome. Now here, what is this? This is our porocytes. As you can see, this is our porocyte, right? The porocyte are right here with negative charge with them. But what will happen is that here you can see slotting off, right? There are no porocytes, and this is what we say, what? Effacement of porocytes. So effacement of porocyte is one of the what characteristics finding that we will find in electron microscope, and this is what confirmatory test for minimal change disease. Now talking about immunofluorescence, there will here in minimal change disease, right? It is immune dysfunction, but there will not be the formation of immune complex. There will be no immune complex formation. As there will be no immune complex formation, right, there will be no what finding in immunofluorescence, right? And it is also called nil deposit disease because there is no finding in immunofluorescence. And another thing is that here in the case of our what, in the case of minimal change disease, another thing that we find is that, right, here at the time of lipiduria, right, at the time of lipiduria, what will happen is that there will be lipid present right here, right, and this lipid, right, the lipid which are present right here in the PCT region, they are reabsorbed into our what, into our cells of PCT, right, in the cells of PCT. As they are reabsorbed in the cell of PCT, what will happen is that after a long period of time, these lipid will be found right in this what, in cell of this PCT. I mean they will be found deposited over the time, right, over the time. As they will be found deposited in the cell of PCT, now this condition is called lipoid nephrosis, right, and lipoid nephrosis. And this lipoid nephrosis is also the another name for minimal change disease, right? This is also another name for minimal change disease. So we talked about two different name again. One is lipoid nephrosis and another is what, nil deposit disease. And this nil deposit disease, what is indicated? This nil indicates that no immune complex. That means we will not have immunofluorescence reading. Okay, now how we are going to treat the patient, right? Now the selective proteinuria, right, is treated by steroid and steroid. So excellent response to that people, right? Okay, now yes, we talked about these diagrams, right? Okay, as you can see right here in the case of minimal change disease, what we are finding, what is this? This is our porocytes. As you can see, porocytes, right? These porocytes are sloughed off, right? You can see right here there are no porocytes, right? No porocytes right here, as this is what, this is effacement of porocytes, right? Now it is mainly present. Okay, this is what, effacement of porocyte. Okay, now quick recap about nephrotic syndrome. Nephrotic syndrome that is most common in children is our minimal change disease, as I've said, that highlight this C right here, right? In the case of what, in the case of adults is our what, FSGS, focal segmental glomerular sclerosis, and in the cases of elderly patient, it is membranous glomerulonephritis, right? And here now quick recap. Here the age of children, they are here the age of children where it is mainly manifested is 2 to 6 years, right? It is also called lipoid nephrosis. Why it is called lipoid nephrosis? Because lipid get deposited into the cells of PCT, right? And it is also called nil deposit. It is called nil deposit because there is no immune complex formation and there is no reading of what, immunofluorescence. And microscopically, what, light microscope, no change, right? There will be lipid in tubule, lipoid nephrosis, yes, it is sometimes seen in light microscope also. And talking about electron microscope, the confirmatory one, that there will be effacement of porocytes, right, and that is what, porocytopathy, as you can see right here also, right? Okay, immunofluorescence, no deposit, nil deposit disease. So clinically selective proteinuria are so response to steroid. So this was about our note description. Now here minimal change disease, let's move toward the content of our first aid. And looking toward the minimal change disease, it is also known as lipoid nephrosis. Yes, we know about these things. Most common cause of nephrotic syndrome in children, yes, we also know about this. And it is most often idiopathic, yes, right? And it is mostly triggered by recent infection. Another eye is right here, and immunization, immune stimulus. So 4i, right? Etiology 4i can be remembered. Okay, rarely it may be secondary to lymphoma, right? Example, cytokine mediated damage. Now it will show, primary disease will show excellent response to corticosteroids, yes. And for diagnosis, light microscope, normal glomeruli, lipid may be seen in PCT, so it is called what? Lipoid necrosis, right? Immunofluorescence reading, there will be negative because of no what? Immune complex formation. Electron microscope, effacement of porocyte will be seen. That is the confirmatory diagnosis. So this was all about what minimal change disease, right? Now after this, the topic of discussion that we'll be having is, we'll be talking about focal segmental glomerulosclerosis. So this much for this lecture. Hope you have a great time. Thank you and enjoy.